Доброго дня, шановні пані та панове. Good day, ladies and gentlemen. We are glad to meet you at the webinar dedicated to the trauma and post-traumatic stress disorders, which is organized by Odesa National Medical University, UNICEF, and Coordinating Center of Cabinet of Ministry of Ukraine Mental Health UA. This webinar will undergo to support the Ukrainian program on mental health. How are you? Under the initiative of First Lady of Ukraine, Olena Zelenska. It's my pleasure and honor to represent you the speaker of this webinar, Professor Chris Brewin. Professor Chris Brewin is fellow of British Academy. He's a fellow of Medical Science Academy in Great Britain and is Emeritus Professor of Clinical Physiology at University of College London. He has developed influential models for the physiological mechanism responsible for post-traumatic stress disorder, so-called PTSD. A particular focus has been the impact of traumatic event on intrusive symptoms such as memories, flashbacks, and voice hearing, and on the sense of identity. He has played a major role in designing and implementing the mental health response to major incidents such as terrorist attack in the United Kingdom, with an emphasis on setting up screening and together with the Fund of the President of Ukraine for Education, Science and Sport, and the Embassy of Ukraine. This was funded by universities of United Kingdom International Research in England and the British Council, and was supported by the Academy of Medical Science, the British Academy, and the Royal Academy of Engineering. And the respected Professor Chris Brewin was the co-head of the panel that was dedicated to the recovery and research of Ukraine in the post-traumatic, post-war period. So please, dear Chris, you're welcome. The floor is yours.
Thank you very much, Valerie, and it's a great pleasure to be with you all today. And I'm interested, your first question, please.
Okay, so we have some questions, and dear visitors and dear listeners, will you please, if you have questions, also ask, and we shall give this question to the professor. So the first question what I have is, what inspired you to research the physiological mechanism of post-traumatic stress disorder?
When I first started my research and was doing my doctorate degree, PTSD had not yet been invented. But I was very interested in depression and in people's beliefs about why bad things happen to them. And I did my doctoral research on an influential theory about how people who are depressed tend to blame themselves for bad things happening and attribute those things to factors that are about them and things that don't change. So, for example, their own lack of ability or lack of intelligence or lack of competence. So when I moved to the Institute of Psychiatry, one of the questions I had was, where do these sorts of beliefs come from? They seem to be very important in explaining depression, but where do they come from? So one of my first studies was with my wife, Bernice Andrews, who had some data on victims of marital violence. And we looked at the accounts that the victims gave to lawyers about their experiences and looked to see those women who, for some reason, chose to blame aspects of themselves, just like depressed people tend to do, for the violence occurring. And we discovered that there were two factors that were strongly related to the tendency to blame yourself. One of them was having people around who blamed you and tried to make you responsible for what was happening. But the second thing was having been exposed to traumatic events in childhood. So those women who had been exposed to physical or sexual abuse in childhood were the ones who were more likely to blame themselves when bad things happen to them later in life as adults. I also looked at these beliefs about bad things, why bad things happen, in people who had been involved in some shipping disasters in the early 1990s. So the sinking of the Herald of Free Enterprise in the English Channel, for example, was a very big event in the UK. And we found that with these traumatic experiences, we found the same relationship. Those people who blamed themselves, aspects about their own character for why bad things had happened during the sinking, were the ones who had the most post-traumatic symptoms and the most depression.
Okay, thank you for the answer. And what I realized that there are two main factors that are composing this situation called post-traumatic disease, as you mean, yes, if I'm not mistaken. How it is being impacted by the war period, by the situation that is where the people are undergoing the military problems in the war area.
And if I may join, sorry,
yeah,
I was late for the beginning of the meeting because we have air alarm in Kiev, and I was, you know, like running through this air alarm through the traffic, so I really apologize for being late. And another question which you probably touched, and I missed the first few minutes or probably not, is with regard to the quantity of people. How can we calculate potentially who would be affected in a way that we can call it PTSD? Because a lot of people in Ukraine are kind of generalizing it a bit too much and saying that everybody has it, since we all lived through the war for quite a while now.
Okay, so first of all, there's the question about how how post-traumatic experiences may arise from combat, for example, and from taking part in military operations. And on the one hand, of course, everybody in the military is together. They are involved in a joint enterprise. Everybody's clear about the goals. So in that sense, you might expect that people would not ever blame themselves for bad things happening. But we all know that in war, often things do not go according to plan. People make mistakes. People fail to anticipate some of the things that will happen. People do things sometimes that in different circumstances they would never do. So even in wartime, there is scope for things to go wrong, and in that situation, people can sometimes blame themselves. They can feel intense levels of guilt and shame about what has happened. For example, they may feel that about they may perceive that they have let down their comrades, and find it very hard to forgive themselves for not having done something that they were expected to do. So even in wartime, the same situations can arise such that people blame themselves and feel very intense emotions such as guilt and shame, which they struggle to deal with afterwards. So I think the second question was about how we can calculate numbers. I think it was Katya, was that the question? Did I remember correctly?
Indeed, because the war lasts already for a while, and there is a discussion how many people are having PTSD already now and potentially might have it now. And we are not talking only about the combat forces, but we are talking about the civilians as well affected by war.
Yes, this is a difficult question to answer, because the concept of post-traumatic stress disorder assumes that the traumatic events are over, are finished, and clearly this is not the case. So you're not in a post-traumatic situation. You're in a traumatic situation that continues. And we know that in those situations, many people will be feeling very high levels of anxiety, sometimes having panic attacks, and that many of those reactions will recover naturally when the traumatic events are over. So in this case, perhaps when there is a ceasefire or there is some resolution of the conflict. So it is not possible with any ease to say now how many people are suffering from post-traumatic stress disorder, because the conditions in which you can measure it are not yet present in Ukraine.
I know Valeriya has lots of brilliant questions, so the next question is for her.
I tried to do my best. So we shall miss the next question we decided to discuss, and we'll come to the next one. Which advice would you give to the healthcare professionals working with patients who have experienced traumatic events?
Okay. Well, there have been some useful principles described to apply to mass trauma and how people are affected by that, and what they need in that situation. So one of the papers that has described this, which has been very influential internationally, describes the principles that in these situations you should try to promote, firstly, a sense of safety. Secondly, calming. Third, a sense of self and community efficacy. Fourth, connectedness. And 5, hope. And there is another model called the ADAPT model, which talks about how the pillars of society are disrupted by mass conflict, and which are the pillars that need to be repaired. And the first one that is described is about safety and security. The second is about bonds and networks. The third is about justice. The fourth is about roles and identities. And the fifth is about existential meaning. So there are some similarities in those two lists. And even though the situation nationally is neither safe nor calm, it may be possible to create smaller environments in which people can have more of a sense of safety and more of a sense of calmness. And the more that can happen, these principles suggest that will be helpful to people in managing temporarily their distress and their psychological symptoms that have developed. Now, in working with people who have post-traumatic stress disorder, it's become very clear to me that that the attitude of listening is extremely important. So in all healthcare settings, not just mental health settings, but in physical health settings as well, hospitals, rehabilitation, people with post-traumatic stress disorder need to feel listened to, and they need to feel as though they can share some degree of control over what is happening to them. So one of the main characteristics of traumatic events is the total loss of control over what is happening to you, and the sense that sometimes that your life is no longer in your hands. So in working medically and psychologically with people who have been through these experiences, anything that you can do to give them more of a sense of control over the processes, so explaining in detail what is going to happen to them in advance, seeing if they can be involved in making some decisions about when things should happen or how they should happen. So that attitude of working collaboratively with the traumatized person is potentially very healing and can strengthen the trust that that person has in the healthcare professional. The other thing that I think all healthcare professionals can do in working with traumatized people is to anticipate what problems they might have in certain situations. So, for example, are there any situations that are likely to trigger a flashback or an extreme emotional response? So are there reminders in the healthcare setting of something that they have gone through in the outside world, in their apartment or on the combat field, which could remind them, perhaps because they are unable to move or they're constrained or things are happening to them which they can't control. It's important to anticipate how these experiences, although they are being done for the right reasons, might still produce an extremely negative reaction of panic and fear. Even though the patient may know logically that they are in a safe place, that people are trying to help them, these responses may occur uncontrollably. And despite the fact they know that they're not appropriate or they don't want to respond, but they will not be able to stop themselves. So sometimes if a traumatized person is having a lot of flashbacks or episodes in which they are dissociating, for example, they are seem to be no longer present in the room with you, they are sort of have retreated into some internal world and you can't talk to them any longer, or they're convinced that they are back on the battlefield, or they are in their block of flats when it is being bombed, even when everybody knows this is not the case. It's important to work collaboratively with the patient to say, is it possible you might respond in this way again? Is it possible in the hospital or in the clinic you might have this reaction? And if so, what would you like us to do? What would be the most helpful thing to you for us in how to respond to this? So often patients who are traumatized will know what are the best things and the worst things that other people can do when they're having a panic attack or when they're having a flashback. And they will feel very reassured if they're being asked about that, if they are sharing in the process, and their views and experiences are being considered in how their healthcare experiences are managed. So I think those are very important principles about working with traumatized people. And I would also say, think about the role of the families and the impact on families, where people are still together with their family. What are the family members doing? Do they understand these reactions that the traumatized person is having? Do they need education about what it means that the person is sometimes withdraws into themselves, sometimes gets extremely angry, finds it very difficult to talk about the experience that they're having. So think about, are these reactions having an impact on the family, on partners, on children? And can the situation be helped by educating and supporting family members to make sure the same principles are happening at home as you are trying to make happen within the healthcare situation?
Okay, thank you, Chris. And
I have, if I may, I have two
Welcome.
small questions
Welcome.
related to what Chris was just saying. First of all, when you were explaining the models, because you explained two models, and in the second model you mentioned roles and identities. Can you elaborate on that a little bit?
Yes, this is the notion that mass trauma often takes away the roles that people have had, either within their family or within their community, and how people may need to rebuild this role after the trauma is over. So these models are mainly concerned with the post-trauma period and helping people not just to deal with the symptoms that have been caused by traumatic experiences, but also to rebuild a life for themselves that may look very different to the life that they had before, in terms of the people around them, in terms of what their role is in relation to the people around them, in terms of how they fit into the community and how they contribute to that community. So that these experiences often take away things that are a major part of the person's identity before the conflict or before the mass trauma, and finding maybe a new identity, because the old one, it may not be possible to come back to the old identity. People often who've been traumatized often talk about that they are different people now. They will never be the same person that they used to be before this happened. And so part of the rebuilding process is not just to think about symptoms, but to think about positive aspects of their lives, and particularly how they connect with other people and how they function to do things that give themselves a sense of meaning and value in the new world which has been created.
And the second, small, related as well to what you were already saying, but just to elaborate a bit. In Ukraine, there is a potential possibility that a patient arrives to the usual hospital, and then it appears in the hospital that the patient has post-traumatic syndrome. And in this case, if the patient has never worked with it before, how you think is the best way for the doctors of this not psychiatric hospital, just usual hospital? What is the way for the doctors to proceed? To advise him to talk to the psychiatrist or psychologist, to call for the psychiatrist, not to do this? So what the practical way, if this is just the first time where they saw it and the patient, basically this is the first time for the patient to be explained and to recognize that this is what is happening to him or to her?
Yes, so I think we are now in a situation where perhaps many medical professionals in hospitals and clinics are becoming sort of, if you like, part-time psychiatrists and psychologists because of what they are seeing every day. So I think it's very helpful if they have knowledge about these conditions and they feel comfortable in explaining to patients why they are having the reactions that they are. Many of these reactions, these panic attacks, flashbacks, irrational fears, will be very disturbing to the patients themselves. They may feel there's something badly wrong with them. They may worry that they're going mad because of these psychological symptoms. So that the reassurance that every medical professional can give them that these are normal symptoms of being in a traumatic situation can be very helpful in immediately providing some of that calming that we have been talking about, and the sense of feeling understood, the sense that there is nothing, that they're not going mad, there's nothing actually wrong with them. So partly I think it is an education that every health professional can provide to their patients, but also the attitude with which they approach them, so that they respond to these reactions, these flashbacks, these strong irrational fears, as though these are normal. These are not that they are problems for the hospital or for the healthcare professional, but that these are normal responses to be expected, and that they can be understood and managed. So the attitude of which we have been talking about, of listening, of asking the person, is there anything you don't understand? Is there anything that you're worried about? Is there anything that we can do to make your situation easier? All those will assist the psychological state of the patient, and also they will probably lead to better medical outcomes as well, because the less frightened and anxious the person is, probably the better their physical response will be to the operations or the other medical interventions that are taking place.
The floor is yours.
Thank you. Maybe I'm a little hurried, but may I suppose that taking into consideration your expertise and your experience, and can we think about creation of some recommendation for us, for our country, for our doctors, that can be useful from your point of view?
Yes, I think these recommendations are already there in the international literature. I think that the principles that I talked about make a lot of sense. They have a lot of international support, and I think they would be a very good starting point. But the other thing I would say is that every situation is different. Your experience in Ukraine will not be the same as the situation of the people who put these guidelines together. You may notice things and feel things are important that are not on the list. But I would encourage you to be confident about adapting these recommendations for your own specific situation, and not imagining that people outside the country can really understand what it is that you're going through and what you need at the moment.
So what will be your recommendation for research on PTSD in our country, and how can we improve the mental health response in our country during the conflict period and after that in Ukraine?
Okay. Well, first of all, it's very difficult to do research in these situations. You can do descriptive research and collect information, and we don't actually, as I discussed, the international literature is almost all about post-traumatic situations. We know much less about symptoms that are present while the trauma is actually going on in a state of continuous threat, as Ukraine is under at the moment. So this is something where I think research could make a very useful contribution. in terms of how people could be helped, I think one of the things to remember is that it is not just about evidence-based treatment, but trauma affects not just the way people's memories of the experience, not just their levels of fear, but also their sense of themselves, their identities. And we know that in many traumatic situations, symptoms are very strongly related to the loss of personal and social resources. So, for example, if the person has lost their house, their employment, their physical health, and their social bonds. And these are basic requirements for life that undermine the ability to have a positive sense of well-being and a positive sense of self. If people are worrying about where they're going to live, how they're going to support themselves, this takes up a lot of mental energy, and it's very difficult for them to overcome specific symptoms or memories of specific bad experiences that they have gone through. So during or after a traumatic experience, the lack of financial and social support has a major impact on what then happens, whether people recover from their symptoms naturally or whether the symptoms continue and sometimes can get worse. And research done after the war in Croatia found that one of the major predictors of recovery from post-traumatic stress disorder was receiving accommodation support. So something very practical. And most of the people working in this area internationally put a big focus on the importance of practical support to rebuild the aspects of the person's life that they need to function normally. That those are the things that can have the biggest gains first. And in some cases that will deal, or these post-traumatic symptoms will become a lot better simply as a result of doing that. And then when after you've attended to those things, then is the time to say, who is still having a lot of post-traumatic symptoms? Can we now bring in our evidence-based treatment to help them with that?
We have some questions from the viewers, because actually people are watching you right now a lot in Zoom and in Facebook and in YouTube. So the first question is coming from the families. So how you can help to the families where they basically on everyday basis are with somebody who is having PTSD. What would be your advice to the families?
Well, I think this is something that should be put together by by you in Ukraine. I think we know a lot about the kinds of things that are helpful. So, for example, there is a post-traumatic stress network for children in the United States that's done a lot of work on working with children and things like what to tell children about when one of their parents is showing post-traumatic symptoms. A lot of it is it's difficult for parents to know how to talk about these things, and this is normal. Everybody experiences this difficulty. So advice about how to talk about things and when to talk about things, I think, could be extremely useful. What sort of language to use? Of course, the language might be a bit different in Ukraine, and the sort of explanations you want to give might be different because of the current situation. So I think you can be guided by many of the things that have been done elsewhere, but also have in mind how it might need to be changed so that it can be practical and realistic within the Ukrainian situation. but certainly knowledge about post-traumatic reactions, knowledge about triggers, about flashbacks, about why people's mood may be very uncontrollable, about why they might suddenly withdraw into themselves and become unavailable to the rest of the family. These are all very common post-traumatic reactions. And the same kind of approach that we talked about with healthcare professionals, asking the traumatized person, what can I do that will make this better? And what can I not do that would make this worse? So finding a way of asking about practical things that person will find useful in the moment, so as to help them control their reactions and to recover as quickly as possible from that. So there are many practical interventions, the educational materials, advice that can be drawn upon in this situation, and I think will be very helpful.
Two more from the viewers. The recommendations to those people who are having panic attacks each time when we have it quite often.
Yes, again, there are specific interventions for panic attacks. Again, normalizing the attack is very important, so that people understand what it is that is happening to them. And we know that often panic attacks are made worse because the person who is having it feels that there is some serious medical problem, or feels that they're going mad, for example. So they have catastrophic thoughts about the panic attacks themselves. And many of the most helpful things that you can do are simply to explain to people what a panic attack is. The fact that it doesn't mean the person is going mad. It doesn't mean they're about to have a heart attack. And that it is something that will finish. And that the more that they can find an environment in which they feel safe, and they can avoid situations in which they experience danger, then the faster those panic attacks will come to a natural end. So a lot of this is about understanding and education, so that the responses make sense to people rather than being terrifying, sort of adding to the fear they already have about so many other things that are happening.
And a couple more from viewers. One is from the healthcare professional who works with the combat in the hospital with the wounded people who came from the combat forces. With regard to flashbacks, how do the flashbacks look like, and what you actually advise about the flashbacks? Because he or she, the person who answered, doesn't see it much, but however is interested to understand how it works.
Yes, so a flashback is a mental state in which the person feels as though the event is happening again in the here and now. So they feel they're actually back in that event at that moment. And this experience can happen on a continuum. So at the one end, the mildest end of the continuum, there is a fleeting sense of the events happening now, but the person is still aware of where they are, who they're talking to, what is happening. At the extreme end, the person may be totally absorbed in the traumatic memory, such that they are unable to, they're unaware of the people who are around them at that moment. They're subjectively living back in that on the combat field, and that is their only reality at that moment. So there is a broad spectrum of reactions that are included under the term flashback, but they are all quite shocking to experience for the patient themselves. They are disturbing, they're very arousing, and hard for them to understand why they are responding in that particular way.
Valeriya, I know you have lots of other questions.
Thank you. I see lots of questions from the viewers, but still I would like to come back a little bit to the theory. As far as I know, you've been taking part in changing of classification of disease ICD-11. What was the key point for changing of the diagnosis for PSD for new ICD-11?
Okay. So the main issue was that PTSD is in the way it is diagnosed in the according to the American Psychiatric Association, it's a very complicated diagnosis. It is, in fact, the most complicated diagnosis in the entire diagnostic manual. There are 20 symptoms. You have to have some of these symptoms, some of those symptoms, some other symptoms. Very difficult for non-specialists to actually recognize when the person is suffering from it. And in many countries, including the UK, general practitioners, family doctors, are not very good at recognizing when people are suffering from post-traumatic stress disorder. So especially for countries where there are very few psychologists and psychiatrists, it's important to have a diagnosis that can be more easily understood if it's going to be practical and useful. So the World Health Organization's principles included making these new diagnoses in ICD-11 as clinically useful as possible and practical for people who did not have specialist knowledge about these disorders. So what happened was that the American Psychiatric Association basically has tried to describe all of the symptoms that you are likely to come across in someone with a severe case of post-traumatic stress disorder. The World Health Organization went in a different direction, which is to say, what are the symptoms that most distinguish post-traumatic stress disorder from other disorders? What are the smaller number of things that can say, yes, this person is more likely to be suffering from PTSD than from generalized anxiety disorder or depression? And based on the many studies that have been done, they focused on three major types of symptom. The first one was this re-experiencing in the present. So we've talked about flashbacks. So flashbacks are one form of re-experiencing in the present during the day. But also people can have the same re-experiencing in the present at night in the form of nightmares, in which they often wake up, they're covered in sweat, and they sort of feel that they're back in that traumatic situation. So the first thing was a move to a more specific type of re-experiencing, focusing on flashbacks and nightmares. The second element, which has to be present, is the avoidance. So people have to avoid either thinking about the traumatic experiences, their traumatic memories, or avoiding certain places or people. Of course, this is very difficult in a combat zone or in a conflict situation. Avoidance of reminders of what is happening is often almost impossible. But mentally, people can avoid by not thinking, not talking about things, and this would be an example of the avoidance. And the third element is the sense that people are currently under threat. So people who are hyper-vigilant, so people who are always looking around them and convinced that something terrible is going to happen to them at any moment. That would be one example of this sense of current threat, or people who are easily startled. So people who jump when something unexpected happening, like the telephone suddenly rings and they're not expecting it. So those are the three elements that have in this new ICD-11 version of PTSD. So there is a narrowing of what clinicians should be looking for, what questions they should be asking. They can now diagnose PTSD with many, many fewer questions than they could in the past. But I'm sure you will be thinking, well, these symptoms, like a sense of current threat, how do they apply to us? Because threat is everywhere, or threat is in many places. Maybe it's not unusual or inappropriate to feel a sense of threat all around you, especially if you live in certain parts of Ukraine. So this gets back to our earlier discussion about why it is so difficult to measure PTSD while a conflict is ongoing, because it depends on certain signs and symptoms which have a different meaning once the conflict is over than they do when the conflict is continuing.
The question, very simple and very nice question from the viewer, Anastasia Bessonova. Can you cure PTSD, or it's only about the remission and then it again comes to you?
I'm very glad that this question has been put, because Valerie asked me to think about sort of misconceptions that there often are about post-traumatic stress disorder. And this was the one I put last, but in a way it's the most important one. The misconception that you can't do anything about it. So in fact, we know that there are effective treatments for post-traumatic stress disorder. And there's been a lot of success in treating post-traumatic stress disorder and bringing people back to a kind of normality. This doesn't mean that they're going to necessarily feel as though they're the same person that they were before. It may be that these experiences have changed something in a permanent way. But we can often bring people back to normality in the sense that their lives are not dominated by fear any longer. They're not dominated by upsetting memories of the past. They're not always withdrawing from people because they can't bear to be in the company of others. So many of the symptoms of PTSD can be successfully treated, and the outlook is positive, but at the same time, you can never return someone to the state before the traumatic event in every respect, and that there may be some changes and adaptations which are inevitable because perhaps of things that have been lost that cannot be replaced, things that have been seen that cannot be unseen. So the future will never be the same as the past, but it can be not dominated by the past and by fear and negative emotions.
Valeriya?
Being the obstetrician, I cannot avoid the question about the problems of such disorders with pregnant patients and young mothers and newborns, having the very small newborns. Do you have an idea of any peculiarity of treating with such kind of patients?
This is not something that I have considered specifically. I've not particularly worked with this group, but I think the general principle of educating people about what post-traumatic symptoms are, what they might notice, describing the situations in which those symptoms are likely to happen, and putting plans in place in advance for what they will do if they suddenly notice that they are getting very panicky or have a strong need to run away, for example. So a lot of things can be managed successfully simply by making things predictable. So getting people to think, yes, I may have this reaction. I understand why I might have this reaction. Now, what am I going to do about it? What plans can be put in place to make myself and my child safe should I have this reaction? And I think those kind of discussion, I mean, every family will have a different solution to these issues, but having these conversations and bringing it out into the open, I think will be very reassuring to people and help them to know that they are doing something to create safety both for themselves and for their child.
Thank you very much. And as far as I understand from all the discussion, being not a psychologist, being not psychiatrist, I understand that the key point of dealing with this problem is communication and continuous support of the people that we are dealing with, if I'm not mistaken, yes?
Yes, I think you're absolutely right. And the other thing is not expecting that these reactions are going to go away very quickly, but they may come later. In fact, they may not even develop until later, maybe even some months or years after hostilities have finished. So we need to be thinking not just about who has a problem now, but also who might have a problem in the future, and how can we communicate with them in such a way that when these problems happen, they will understand what is happening and they will know what to do about it. And this is one of the main lessons of responding to traumas like terrorist attacks, for example. Countries all over the world have been very bad at doing this. The immediate response is often very successful, but the long-term mental health response usually fails because they don't put in place, they don't expect what the problems are likely to be and what they will need in order to make sure that those people who develop problems later understand what is happening and have a route and people to help them to get the treatment they need.
And what about medications? What would you, is there anything evidence-based in terms of drugs? There are questions from the viewers on that. So do you use drugs in PTSD, pills, and what is evidence and what is the mythology around this, the whole medical part of it?
Yes. So I'm not a psychiatrist, so I cannot speak with authority about this. But there are certainly some antidepressants that are recommended for post-traumatic stress disorder. The National Institute for Clinical and Health Excellence in the UK has a website which has recommendations for specific types of medication. Also in the US, there are recommendations for what medications may be effective. But drugs are not a first-line treatment. So they are something that can help manage symptoms, especially when people are not in a state to start psychological treatment. They have an important place in the management of post-traumatic stress, but they don't cure it. They don't solve the problem, but they can be very helpful in the short term when people have overwhelming feelings that they're struggling to control.
So thank you. It was my last question. How can society, not individual, but how can society support those individuals who are struggling with PTSD?
Thank you, Valeriya. This is a very important question again. So looking ahead, one of the things society can do is to keep mental health on the agenda, despite all the competing demands that there will be when the hostilities have finished. The second thing, not underestimating the enormous change in attitudes and habits that are involved in the transition to a peacetime society. So people will have got used to a different type of normal, and it will not happen overnight that they can return to a different way of doing things. We've talked about problems of delayed onsets, of planning for people who may not develop problems until much later. Also, I think consider the specific geographical and political situation in Ukraine and how this affects the needs of specific groups. So people in different parts of Ukraine, for example, people from different linguistic backgrounds, how their needs may differ, and how in Ukraine you may have to develop new solutions to problems because of the particular way in which the country and your inhabitants are distributed and the experiences that they've had, not just over the last 3 or 4 years, but for over many years. And the final thing I would say is to have leadership from the top about how these post-traumatic reactions are normal and can be treated. So it's very helpful if you have military leaders, for example, who talk about their own symptoms and their own experience of treatment, or you have politicians who talk about that, or people who lead opinion in Ukraine can talk openly about their own difficulties, their own reactions, and what has been helpful for them. That kind of leadership, I think, will be really helpful in making sure that everybody who can benefit from treatment and intervention does so.
Since we are 1 hour on this air for the moment, so several things which I would like to say in the end. First of all, I would like to thank Valeriya for making the introduction. And second thing, thank you very much for agreeing to come and be with us and respond to the questions. And due to the volume of questions and the interest which I can see in people who were from the beginning till the end, even growing the numbers of people on all the platforms where we are for the moment, we would like to ask you in a while, when you have time, to come for the second episode of this talk, if we can call it talk or conversation, if you will allow us at a certain point.
Yes, I would be very happy to do that.
You mentioned leadership, and I would like to say that we, by being in this on this air, we are as well supporting the initiative of the First Lady of Ukraine, who put the mental health as one of the top priorities, and even the summit of First Ladies and Gentlemen this year was devoted to the mental health, and we had a special guest from Great Britain, Stephen Fry, whom you know very well, who was speaking openly about the mental health issues. And I see that some of the viewers were asking questions about how to help people who lost their loved ones. We might talk about it in the next episode, but I as well advise them to open on our channels. There is a specific interviews related to this topic with Alexander Gershanov, Israeli psychologist, because it's one of the top topics in Ukraine right now, because every day somebody loses somebody close, and this is one of the big topics. So again, thank you very much to Valeriya and Odesa Medical University. Thank you very much to you, Chris, and we hope that quite soon we go with the second episode of this conversation.
Thank you very much.
Thank you, Chris. Thank you, Catherine, for inviting us. Thank you very much.